Good evening, everyone. I would first like to thank Professor Mahmoud Alsalem for giving me this chance to share in this interesting webinar and to share with this distinguished group of oculoplastic surgeons from Europe and the Middle East. My talk will be about the eyelid changes in thyroid eye disease, and I will try to focus on the clinical issue and be as simple as I can. It's not surprising that, can you hear me, everyone?
Yes, okay. We can hear you very well.
Okay, it's not surprising that thyroid eye disease has been given many nomenclatures. Of these, thyroid ophthalmopathy, Graeve's ophthalmopathy, and Graeve's orbitopathy. And this points to the fact that of the many and varied clinical presentation we get in this disease. Now we all know that it is an organ-specific autoimmune mediated inflammation affecting the soft tissues of the orbit, the extraocular muscles, and the periorbital connective tissue. And it affects adults, about half of the adults with thyroid dysfunction. It can affect any race, but Caucasians usually are more affected than Asians, and women are affected 4 times more than men, with a bimodal age distribution in the early 40s and 60s, 5 years earlier or younger than their men, contributing men. Thyroid eye disease is treated by many specialties, but we as ophthalmologists, we have an important role first to make an accurate diagnosis through our clinical examination, clinical signs, the lab, with the help of orbital imaging, together with the history of thyroid dysfunction. We have to know that we may have almost maybe near to 90% having hyperthyroidism, but we shouldn't forget that sometimes we have euthyroid function in Graves' disease, sometimes hypothyroid in Hashimoto's cases, or even in thyroid carcinoma, but they are very rare cases. Other than this, we have to provide education, emotional support, and to treat in the congestive or active phase to maximize comfort while preserving vision, and in the stable phase to restore function and appearance. A very frequently encountered sign in thyroid eye disease, sometimes more than 90% at some stage, is the upper lid retraction, or what we call the Dalrymple sign. We know that the normal position of the upper eyelid is that it covers about 1 to 2 millimeters from the superior limbus, while the lower eyelid passes tangent with the inferior limbus. So if we have this level in the upper eyelid higher or in the lower lid lower, we speak about lid retraction. It can occur either unilaterally, bilaterally, one or both eyelids, with or without exophthalmos, and it is responsible for many functional and cosmetic problems in these patients. Although it is very common, but it is not pathognomonic as it can be seen in other conditions. This retraction is usually an early feature in hyperthyroidism. But again, as I mentioned, we can see it in euthyroid cases or even hypothyroid patients. It is variable. We can see different levels of retraction during the subsequent visits of the patients. It may be transiently worse in acute thyrotoxicosis, or sometimes over-medication with thyroxine due to the increased sympathetic tone. Although it can improve partly or partially as the thyrotoxicosis is treated or the orbitopathy stabilized, but it is most likely to persist chronically, and it rarely resolves on its own even after orbital decompression. We can grade eyelid retraction into mild, moderate, or severe according to the degree of retraction. If it is at the upper limbus, it is said to be mild. Up to 4 millimeters of scleral show moderate, and more than that, it will be severe. Although it is not pathognomonic, but this lateral arching, what we call lateral flare, is pathognomonic of thyroid eye disease. And it is thought to be due to the presence of inflammatory reaction more in the lateral part here, the lateral horn of the levator palpebrae superioris, in the region of the lacrimal gland, leading to scarring between the lacrimal gland fascia and levator, and leading to this lateral flare. And accordingly, another useful clue here, if we ask the patient to look to the right and to the left, we'll see that there is more widening of the palpebral aperture on adduction of the eye. So this again proves the fibrotic lateral attachment of the levator aponeurosis. Many explanation has been given for eyelid retraction. In the upper eyelid, as we know, in the congestive phase due to the Muller's muscle overaction from sympathetic stimulation, other causes like contracture of the levator due to its direct involvement, or adhesions of the levator to the orbicularis muscle and orbital septum, and finally, it as a response to the hypophoria due to the fibrosis of the inferior rectus, there will be an overaction of the levator superior rectus complex leading to this retraction. While in the lower eyelids, it's somewhat different from the upper eyelid. It is due mainly to fibrosis of the inferior rectus here by pulling on the capsulopalpebral ligament through the attachment to the tarsus, leading to lid retraction in the lower eyelid, and a very minor role for adrenergic stimulation of Muller's muscles. Of course, it correlates very well with proptosis in the lower eyelid retraction. We have to take care because sometimes lid retraction is a fake one. We call it pseudo lid retraction, pseudo upper retraction, due to pull of the globe by the tight inferior rectus. And so the management here will not be on an upper lid surgery, but rather recessing the inferior rectus to correct this pseudo lid retraction. Another important sign is upper eyelid lag. We call it von Graefe sign. And it is seen by asking the patient to look or make a pursuit, vertical pursuit, from the up gaze up to down gaze, and we'll see that the upper eyelid is lagging behind the globe. Although it supports the diagnosis, but again, it is not pathognomonic for Graves' orbitopathy. Another important sign also, which denotes the fibrosis and the tethering of the posterior lamella, is Grove sign, where we can pull on by pulling the lashes of the eyelid downwards, and then we'll see that there is a resistance to this pull together with preservation of the crease. This is an important sign because if the posterior lamella is not tight, there will be a full stretch of the anterior lamella. Again, it indicates, as I said, the levator muscle involvement. Many other eyelid signs were described with different eponyms, and all of them are based on the fibrosis of the levator complex or the extraocular muscles. So the reciprocal of the von Graefe sign is mean sign, which is a globe lag. So when the patient when he's looking from down gaze to up gaze, there will be a lag of the globe behind the eyelid. Another sign, the Stelvach sign, where is the incomplete blinking. Trousseau sign with reduced amplitude of blinking. Sometimes we can see tremors of the closed eyelids. We call it Rosenbach sign, or spasmodic retraction of the upper eyelid during fixation. Kocher sign, inability to hold fixation in lateral gaze. Zucker sign, contraction of the frontalis in the up gaze, and difficulty in everting the eyelids again due to the tethering of the posterior lamella, which is called Gifford sign. All these together leading to lag of thalamus, in addition to loss of the Bell's reflex, again due to the tight inferior rectus and the incomplete blink, altered deep tubes, all these will lead to affection of the cornea, leading to ulceration and superficial epithelial defect. And in the extreme cases, this may be a sight-threatening condition, leading to not only desiccation and ulceration, but even, as we see in the lower picture, in melting of the cornea and perforation and even loss of the globe. Now, we have to determine the phase of Graves' orbitopathy at each clinical assessment. This is fundamental to formulating an appropriate management plan. And we know that first we have the active phase, followed by the stable phase later on. Activity, and it is given forth by Moritz et al. We have many points. Each one is given 1 point, and the cutoff value is 4. If you have 4 points, this means that this patient is in an active state. Regarding the eyelids, we have 2 points, the redness and the inflammatory eyelid swellings. Redness may be also due to inflammation, maybe at the lid margin, mimicking like blepharitis, or in the preseptal skin. And the swelling is due mainly to impairment of the venous drainage, leading to increase in the interstitial fluid in the orbits. And as there are no lymphatics posterior to the orbital septum, this fluid escapes anteriorly, and together again with the orbital fat, herniation will lead to the subcutaneous fluid and thickening of the skin and the swelling that we can see in the eyelid. And this is considered as a sign of activity. We can categorize it either moderate or severe by asking the patient to look down. And in the upper eyelid, in severe cases, we'll find that the fold will be rounded, while in the lower eyelid, it will fold in contradistinction if the patient is looking straight ahead. It is moderate, doesn't fold. Management is challenging because of the variable presentation and clinical course. First of all, we have to normalize the level of thyroid hormone by the help of our endocrinologist colleagues. And usually in about 80% of cases, the disease is mild, and it will need just assurance and support, giving advices to patients like stop smoking, low salt diet, protective sunglasses. And we continue this conservatism until about 6 to 12 months with stabilization of our measurements of the eyelid and normalization of the thyroid function. Other non-surgical measures that can be given for periorbital edema, just ask the patient to elevate the head with more than 1 pillow. For the ocular surface irritation or injection, advising the patient to take lubricant eye drops by day, ointment by night. Some drops can be described like guanethidine, 2%. It's an adrenergic blocking agent, but it was found to be unpredictable, giving to conjunctival hyperemia, miosis, epithelial toxicity, and limited long-term effect. Also, we can use Botox to be injected 5 to 15 international units, either subconjunctivally or subcutaneously in the levator mollusc complex. But again, here, it should be individualized because we may get variable outcome, transient diplopia, ptosis in maybe 10 to 20% of patients. Also, one of the main immunomodulator treatment is glucocorticoids in active cases. But again, here, we can give it for other active cases, but it is usually not helpful for strabismus and eyelid retraction. So we are left with surgery, and a simple procedure can be done that can salvage sight. Sometimes, can you see this patient with jelly roll edema, proptosis, and exposure of the cornea with starting ulceration. So a simple procedure like lateral tarsorrhaphy as a temporizing procedure until we give the patient his corticosteroid intravenous treatment, we can salvage vision in such cases. Another case that almost lost her eye in the right eye, and also again we can do the same lateral tarsorrhaphy to save the vision in the other eye until the condition is controlled. Usually in the stable condition, we have a sequence for rehabilitative surgery. And of these, the eyelid surgery usually comes at the end, last thing, after decompression and extraocular muscle surgery if it is needed. And indication for surgery for the upper or the lower eyelid for retraction, if it is significant, asymmetry of the palpebral apertures, especially lateral flare, if there is increased pre-aponeurotic or subdermal fat. And we have to know that especially in lower lid retraction, together with proptosis, these cases will not respond to lower lid lengthening because of the negative orbital vector with the proptosis. So the response will be poor, and these cases will respond to orbital decompression better than eyelid surgery. A wide variety of techniques for lowering the upper eyelid, lengthening the lid, mainly by resecting the levator of aponeurosis together or singly by mullerectomies or combined surgery. We can use with or without spacers. And of course, the lateral flare necessitates we have to cut the lateral horn of the levator aponeurosis. I used to use spacers maybe a decade ago, and spacers act as a barrier for re-advancement. After recessing the levator complex, it may re-advance. And again, also it has a compressive effect exerted in a downward direction in the upper eyelid or the reverse in the lower eyelid. Of course, it is used more in the lower lid retraction to act as a scaffold and help overcome the effects of gravity. We can use autogenous material like hard palate graft, auricular cartilage, non-sclera, or biocompatible material like expanded polytetrafluoroethylene. It was done by FCI, but I don't know why they stopped manufacturing it for the time being, or porous polyethylene also. So this is the eyelid patch that was done by FCI. It's a omniporous material, biocompatible, that is used to as a spacer between the tarsus and the levator aponeurosis. So after doing the levator recession, we can make the patient sit down, and whenever we get a good level of the eyelid, we then start to insert the spacer. So as you see now, this is preoperative and postoperative pictures of some of the patients done at that time with the use of spacer. We can get a very nice level and very nice contour of the eyelid using this spacer. Nowadays, and it is described by Leo Cornefe since the 90s, he described a full thickness graded blepharotomy technique where we cut through the levator aponeurosis, Muller's muscle, and conjunctiva. And it proved to be both effective and predictable in patients with mild to severe eyelid retraction. This is my favorite technique nowadays. And I'm proud to have this schematic drawing by my mentor, Dr. Mr. Jeffrey Rose of Moorfields, by his own hand drawing, the technique. So we make first an incision in the crease at 7 millimeter in the center, and then after dissecting the orbicularis and undermining till we reach the upper border of the tarsus, we start dividing the tissues, the levator, Muller's, and muscle, and conjunctiva in the temporal half, about 80 to 90% from the temporal dimensions of the upper tarsal border, leaving only 10 to 20% medially. And then the next step is to cut through the lateral horn up to the superior orbital margin, but take care here not to damage the lacrimal gland. And finally, we close the orbicularis by inverted sutures and the skin by 6/0 nylon, leaving the posterior lamella open. Adopting this technique, again, we reached a very good result. This is the second eye. This is the first eye done before, and the second eye just at the conclusion of surgery, doing graded blepharotomy. Again, also this case, doing graded blepharotomy directly at the end of surgery. You can see that the lateral flare is totally corrected, and the contour of the lid is satisfactory. Of course, there are complications of the surgery. We can get overcorrection, especially if we are dissecting the aponeurosis and Muller's muscle too far medially. So there will be flattening of the medial contour or undercorrection, leading to temporal obliquity. We may get asymmetry, lid crease recession, or with the use of spacer, we may have a thickened eyelid, and of course also other complications like extrusion, shrinkage, or migration of the allograft material spacer. This is the end of my talk, and I would like to thank you all for your attention.
Thank you. Thank you very much. It was very helpful.